So I know that we have a great presentation today, and we're going to open up the webinar. So welcome everybody to our webinar today, which is Black Mental Health Matters, Microtrauma and Microaggressions in Communities of Color. And this is part one. Today's date is February 11th, 2021. My name is Mark Durgan. I am the project director for the Pennsylvania Care Partnership. We are the statewide system of care grant. Welcome everyone to today's webinar series provided through the PA Care Partnership in association with the Office of Mental Health and Substance Abuse Services. We have over 2,000 people in attendance today, or at least that's what we're scheduled for, and some will be watching on Zoom and some others will be watching on YouTube. Our moderators today are Nancy Massey and Jamal Ford, both with PA Care Partnership, and they'll be monitoring chat and Q&A as well as the YouTube for comments. It is my pleasure to welcome Dr. James Peterson, who will be introducing our presenter. Dr. Peterson is a writer, educational consultant, content creator. He's a graduate of Duke University and the University of Pennsylvania. He is also the founder of Hip Hop Scholars, Inc., an association of hip hop generational scholars dedicated to researching and developing cultural and education potential of hip hop, urban and youth cultures. Dr. Peterson, I'll hand it over to you.
Thank you so much for that, Mark. Welcome, everybody. We're so excited that everyone is here, all of the professionals and the students and the community members. And I also, just before I introduce my extraordinary sister, I do want to say thank you to the PA Cares team, Nancy and Jamal and Mark. Each one of these presentations takes an extraordinary amount of work, and we've been on a lot of meetings and they've had to handle a lot of logistics. So just thank you to Nancy, Jamal, and Mark for all the work that you did to make today possible. Dr. Eunice Peterson, who will be delivering remarks and presenting materials to this group today, is a board-certified adult and child and adolescent psychiatrist who's a proud graduate of Meharry Medical College in Nashville, Tennessee. She completed her psychiatry residency as well as her child and adolescent psychiatry fellowship with the University of Maryland Sheppard Pratt program. Dr. Peterson is currently an associate professor with the University of Texas Southwestern Medical Center and the lead consultant for Onyx Psychiatry and Wellness Practice. Dr. Peterson has an abiding interest in advocacy, psychoeducation, elimination of healthcare disparities, eradication of mental health stigma, and the promotion of mental health and wellness in our communities. Dr. Peterson will be speaking to us today on Black Mental Health Matters, Microtrauma and Microaggressions in Communities of Color, Part 1. Black Mental Health Matters is a two-part webinar facilitated by Dr. Eunice Peterson. The webinar is interactive. There will be some Q&A. We're going to try to reserve more time for Q&A at the end. And it's designed to provide participants with an understanding of how racism impacts mental health. In Part 1, Dr. Peterson will present information on the history of racism in healthcare, the stigma of mental health care in communities of color, and the various challenges that healthcare professionals and patients face in mental health and wellness in communities of color. Without further ado, I would like to turn the program over to Dr. Eunice Peterson.
Good afternoon. Thank you for that gracious presentation. My name is Dr. Eunice Peterson, and I must echo the thanks that Dr. Peterson offered. I greatly appreciate the talents and the efforts of Mark and Nancy and Jamal, as well as Dr. Peterson in making this opportunity a possibility. I'm grateful to have the opportunity to share information with you. As Dr. Peterson mentioned, this is a two-part series, and we originally designed the information to be geared towards, with part one, the provider community, and then part two, the consumer and community. But we've actually adjusted it so that we can make sure that we are providing information that's relevant for all people who are joining us, and we're so grateful that you are. So, I have nothing to disclose. Dr. Peterson has nothing to disclose. And we're hoping that when all is said and done, you'll have some more information on how racism impacts overall health, how it affects the key determinants of health. And we want to be solutions focused. So we want to make sure that we provide you with some information and some resources on things that we think would help us to mitigate the effects of racism. So this is my homage to people who actually serve in the military. Bottom line up front, or a bluff statement. So racism kills. That is not a euphemism. It's not a hyperbolic statement. It's actually now what we know to be scientifically true. And there's a growing body of research that's helping us understand how it is that racism is actually killing us. It impacts the social determinants of health, and it diminishes our capacity for achieving mental health equity. This is our approach. So I think it's important for us to talk about things. And then once we talk about things, we need to think about them. Once we think about them, then we need to take action. And that's how we will get transform or change. That's how we'll bring about change. And so I want you to consider the approach as we present information. We want to talk about it. We want to think about it. We want to take action, and that should lead to transformation. There are many definitions for mental health. And one of my preferred definitions of mental health is from the World Health Organization from 2014. And that captures mental health as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, and can work productively and fruitfully and give back to their communities. I don't think that this is just a definition that's appropriate for mental health. I think overall health would best be served by a definition like this. So this is not a static definition, it's a continual state of being, and this is our overall goal. So when we're talking about things like racism or the other or perceived discrimination, I want us to keep in mind that we're looking at what our overall goal is, which is to achieve mental health equity, to achieve mental health, that everybody has equal access to mental health resources. So for most of you, I'm sure you're aware that mental health is not just the absence of disease. It's an integral part of health. There is no mental health, or rather there is no health without mental health. And it really is affected by socioeconomic, biological, and environmental factors. Many of you may have seen this image before that is trying to show how we're transitioning from a goal of equality to equity. But I want to encourage you to look at it again. So I find that when I take the time to look at this image, I learn something new. And I may not be the most observant of people, but I actually learned something new at looking at this picture 2 days ago. So in the on my screen, on the left side for the equality picture, I see that there are 3 people standing on the boxes. On the right side for equity, what I hadn't noticed before, so what I noticed before for equity was that now that the younger child is actually able to look and see the game. And so in order for him to be able to do that, he had to be able to stand on 2 boxes. What I realized 2 nights ago is that they took the box from the adult. So equity is not just about making sure that people have appropriate resources. It's actually reappropriating resources. So some people who were getting things before may not be able to get them to the same extent in order for those who did not have enough to begin with in order to be able to achieve that equity. I also noted, and that therein lies some of the challenges in terms of establishing appropriate policies and getting the support that we need on the individual, community, and government levels in order to achieve equity. So that's what was impressed upon me from this picture. But I also noticed that the person in the middle who was able to see during the equality scene, on the equity scene, he's sort of checking out the person on the right. And I think there might be a little bit of haterishness going on because he's looking to see what that person is doing. So, even though some of these things might be familiar to you, this might be more of a review than an introduction of new information. I want to encourage you to take advantage of the opportunity to continue to expand your horizons and broaden your perceptions. So we have an idea of the things that are interfering in our ability to achieve mental health equity, right? So we have a growing awareness of the fact that things like if someone has to choose between making a mental health appointment or going to work, they're likely going to go to work. If someone has to choose between paying for medicine or paying their rent, they're likely to pay their rent, right? So what we need to continue to try to invest in is a greater understanding of the more nuanced barriers that prevent people from being able to access mental health or being willing to access mental health. Things like health behaviors, right? That can be really culturally specific, that incorporate attitudes and beliefs. And that's where understanding the historical context of the interface of racism and mental health becomes so important. So in 2001, the Surgeon General identified stigma as the primary issue for people of color accessing mental health care resources. But what we're going to propose is that racism forms as much, if not more, of a barrier to accessing mental health care, and that there's actually an overlap of stigma and racism that combine to really cause some significant barriers to mental health care in the African American community. So I wanted to share with you my trauma from medical school and college and also high school, where we have pop quizzes. And so this is my version of true or false. This is absolutely voluntary, but I encourage you to test yourself. Fact or fiction? 45% of Black people believe that a mental health condition is a sign of personal weakness. Fact or fiction? In my mind, I'm hearing the Jeopardy theme song going on, but we're not going to give that much time. So 5 more seconds. If you selected fiction, you were correct. It's actually 63%, right? So more than 1 out of 2 African Americans believe that if one, oh, thank you for sharing that response. So 63% is the actual percentage from a study that was done that you can access through the National Mental Health Association, where it shows that people believe that mental health is a condition of personal weakness. And they go on to share different percentages of the fact that certain people would not be willing to participate in treatment or take medication if it was so indicated. So interesting study. But that said, where there's this perception in the African American community that mental health is a sign of personal weakness is actually tied in our history. So let's talk a little bit about stigma, which I will do if I can advance the slide. So as the Surgeon General said in the study that he released in 2001, stigma is considered to be the primary issue. And there are different types of stigma, but I'd like us to focus on 2 particular types, and I'm not able to advance the slides. So the two types that I would like to focus on are internal stigma and structural stigma. With internal stigma, that's when someone actually takes the public stigma, so the public prejudices and biases, and actually internalizes them regarding mental illness. And when someone internalizes the stigma related to mental illness, then that makes them, it affects their self-concept, it affects their self-esteem and self-confidence, it affects their willingness to recognize when they have symptoms of mental illness, it affects their willingness to access care when they are dealing with mental illness. And then once, if they get to the point where they are in care, it actually affects their willingness to adhere to treatment recommendations. Thank you. So that's the internalization or self-stigma that I'm discussing. The other component of stigma that I think it's important to consider is the structural stigma. So structural stigma, that really talks about the layers of stigma that have developed over the history of our country, where stigma towards mental illness has been incorporated into our policies, our practices, our general beliefs, and it ultimately results in less opportunities for people who have mental illness. So I specifically chose those types of stigma, the internal or the internalized or the self-stigma and the structural stigma, because as I mentioned, there's some parallels between stigma and the types of stigma and the types of racism. Next slide, please. Next slide, please. So this is a multiple choice question, because as you know, this is the preferred way of testing when we're in medical school. So which is the misnomer? Which is the misnomer? Racism, white supremacy, reverse racism, anti-racism. Which is the misnomer? 5 more seconds. So if you selected C, you were correct, and yay, you were correct. So I want to make sure that as we're continuing in our conversation, that we actually have a shared understanding of what terms are. And if we understand racism as a system where there's an oppressor with power and those who are oppressed with less power, then there's not the capacity for reverse racism as such. It doesn't mean that people cannot be prejudiced. It doesn't mean that people cannot have biases, but there's not the capacity for reverse racism. And we'll talk a little bit about racism and anti-racism as we continue. Next slide, please. So just briefly, again, because I want to make sure that we have a shared understanding, race is just a social construct that was based on phenotype. So basically the way that people look and sometimes certain characteristics, and it was basically established, I think, to contribute to a hierarchy in our society. And then for the purposes of this presentation and how I tend to use discrimination, it's just acting upon prejudice or biases. And we'll talk a little bit more about racism in the next slide. So I find that third one is a sociologist who has done a lot of research on racism and on health and how they intersect. And I think it's really important how he captures the phenomenon of racism. So when he talks about racism involving an existential inequality that diminishes agency and personhood, and then also allows for the fact that there's an inequality that's involved that actually affects people over the course of their life, it really helps to underline the fact that there is a growing body of research that the disadvantages of discrimination, racial discrimination, actually begin before birth and just continue throughout the lifespan. And the consideration of that is going to be important if we really want to try to prepare ourselves to be as culturally competent as possible. Next slide, please. As I have a preferred definition for mental health, which is by the World Health Organization, I have a preferred definition for racism, which is from Dr. Kimora Jones. So she tells us that racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks at that. So basically how one appears, one's race is determined by appearance. So the system of racism is based on somebody's appearance. And it does three things. It unfairly disadvantages some individuals and communities. It unfairly advantages other individuals and communities. And I want to stop right there because again, I won't say that I'm necessarily the most observant person, but in my upbringing and in the way that I was exposed to understand how racism was, and considering the fact that I am an African-American female, I think that my understanding of racism more heavily depended upon the idea that racism conveys unfair disadvantage to a certain group. So I focus on the fact that racism involves disadvantaging a group. I didn't really understand how important it is to understand that it also unfairly advantages other individuals and communities. And I think that if we try to better understand the unfair advantage that racism has conveyed in our society, then it will, number one, better explain some of the social issues that are now prominent in our society. And it'll help us better understand how to communicate about a topic as sensitive as racism. And I also think that for some reason, there is maybe an intertwining of race and racism that helps to diminish the emphasis or the fact that racism conveys the unfair advantage versus the unfair disadvantage. Now, the third component of racism that Dr. Jones talks about is that it saps the strength of the whole society through the waste of human resources. And essentially what that means is that if you believe that we are all equal, that all people are equal and should have access to equal opportunity equally, and every person has equal potential, then if a certain section of our society is devalued and dehumanized and not given opportunities, then we might be missing, or we might be suppressing or oppressing the next Einstein, or the next person who's going to be able to find a cure for cancer, or the next person who's going to be able to find a cure for diabetes, or who'll be able to introduce a new form of government that will allow us to be more healthy and appropriate. So that's, I think, the point that she's making with sapping the strength of the whole society through a waste of human resources. And that also helps to really emphasize the point that racism is not just an issue for Black people. It's not just an issue for the oppressed or the people of color. It's an issue for our society. And so next slide, please. There are arguably several forms of racism. The ones that I'm going to try to talk a little bit more about are what is internalized and then structural. And like I said, I'm really trying to emphasize that there is an overlap between internalized stigma, internalized racism, and then structural stigma and structural racism. Next slide, please. So again, a different way of talking about racism is that it really involves a series of policies and practices within institutions and systems of power that lead to unequitable outcomes for people of color, and then advantages for white people. So when we talk about individualized racism, it's when someone will actually accept the public perception or the idea that being Black is less than. And again, that affects one's self-concept, one's self-esteem, one's willingness and maybe even ability to achieve their potential, because they've decided to believe that they are less than and deserve less than. And that's the internalized racial oppression. Whereas those who believe that they actually are entitled and who believe that they have a right to more, that they are actually better, really does a good job of, I think, summing up what we call white supremacy or internalized racial superiority. So next slide, please. With structural racism, again, it's just this layer upon layer of the result of the belief that some people are less than, that they're less than human, that they don't deserve rights, that they have less potential, and the building of a society around on that premise, and that history, that how it has shaped our culture, the anti-Black ideology, all results in people having less opportunities if they happen to be people of color or Black. Next slide, please. Now, you may have already seen this wonderful metaphor for structural racism. And if I understand correctly, there's something like 1.4 million views on YouTube of this, but we're talking with Dr. Peterson, and we both agree that there should be something like 100.4 million views of this, because it just is so good. And again, if you've seen it before, I'm going to encourage you to see what you can learn from it from watching it, because every time I watch it, I focus on different things and I learn something new. So this is an example, a well-done example of a metaphor of structural racism. Please play. And so there is a hyperlink up in the right hand corner, right underneath the word opportunity, if that, okay. Thank you. So, at the end, it says that affirmative action can help to address some of these issues, but the more generally, this is a systemic or a structural issue, and it's going to take actually adjusting or challenging our systems and our government to incorporate policies that will recognize and then address the issues that really are responsible for some of the reasons why there is failure to thrive, if you will. And so I think when people hear the word reparations, that it has a certain connotation and it makes people feel a certain way, but reparations is not just money. Reparations really involves recognition of what that video just showed so well. Next slide, please. So we're going to take a little bit of time now to talk more about some of the ways in which racism has predisposed Black people to really not feel as if they can, number one, trust the United States government, or number two, trust the medical field. And we actually have some information about the role of mental health or psychiatry in the building of that distrust. So I want to talk really briefly about some of these things, and then we'll move on to offer a little bit more in detail. So Sarah Barton was a young African female who is an extraordinary example of the objectification of the Black body, if you will. And I believe that she also represents the fact that even when there has been progress in society, we don't necessarily know how to change the ills of the past because they persist in the present. So she was objectified for her physical appearance, and and I specifically did not include a picture of her in this presentation because I don't want to contribute to the objectification of her appearance. But she was essentially shown in freak shows around the world because of the size of her buttocks and the size of her labia. And so she was shown in freak shows and in scientific demonstrations, and she died very young at the age of 25. And her story is worth researching, learning about, to make sure that we can do a better job of being more sensitive to females in general, but to the perception of African-American females in particular. And although she died, I believe it was in the early 1800s, after she died, they actually took parts of her body and continued to show them at freak shows and then later in museums. And it wasn't until there was a large enough public outcry that her remains were returned to her homeland in South Africa, and that was in 2002. Around the time of slavery, there were also practices in which the African Americans were required to dig up Black bodies and make them available for dissections so that medical students could learn more about the human anatomy. I think people are quite familiar with Henrietta Lacks and the fact that there was not informed consent regarding the use of her cells, and the story is tragic. And again, another opportunity to learn more about what leads people to have a distrust of the system. The experiences that history tells us are in no way going to capture the realities of what people have experienced in the past or currently, because we don't do a good job of documenting and then sharing the stories of the oppressed. So with the surgical experiments on enslaved people, I just want to in particular mention that of Dr. J. Marion Sims, who is known as the father of gynecology. He was able to develop a surgical technique for vesicovaginal fistulas, and the way that he was able to develop that technique was by performing gynecological surgeries without anesthesia on enslaved women. Next slide, please. Please go back one slide. So there was a doctor by the name, or physician by the name of Samuel Cartwright, and he proposed that when Africans were attempting to escape slavery, it actually signified a mental illness called drapetomania, or otherwise known as runaway slave syndrome. And what he proposed is that the etiology of this mental illness was when slaves were being treated as equals by their masters. So if a slave was treated as an equal by their master, then that is what led to this drapetomania, the treatment of which often was amputation of extremities. Also, during the time of slavery, there are historical accounts that suggest that when people did suffer from and express symptoms of mental illness, they were punished for it. And so there were goals to try to subterfuge those symptoms or to suppress them. Next slide, please. So dysesthesia ethiopic is another mental illness that was proposed by Dr. Cartwright, where he was trying to explain why enslaved Black people were lazy. It's also known as rascality. And what he proposed is that African slaves had a certain condition of their skin, as well as a certain mental lethargy, which was related to them possibly being sullen and dissatisfied without cause. as they are enslaved. And what he recommended was that the skin be washed and oiled, and then a broad leather strap applied to it as treatment for this disorder. In other words, to quote him, to whip the devil out of the slave. And so not only was that the treatment, but he proposed that once that happened, the slave would be rather grateful. In fact, to quote, he said that the slave will look grateful and thankful to the white man whose compulsory power has restored the slave's sensation and dispelled the mist that clouded his intellect. So the early accounts of how the majority culture tried to make a disease out of social conditions that they were actually causing is something that I think has built some of the distrust that exists, not just in the medical field, but also in the mental health field. There's also studies that show that in the 60s and 70s, there were a disproportionate number of African-American males who were diagnosed with schizophrenia, but really that was to capture how they were advocating for their rights in the civil rights era. Next slide, please. So not really going to go too much into the eugenics movement, which occurred in the United States, which Hitler used to justify some of the things that he did during his reign of terror. But I will talk to you about briefly Mississippi appendectomies, which is a term that was coined by activist Fannie Lou Hamer. And essentially it is a term for coercive taking away the reproductive rights of people without choice. So it doesn't allow for the woman to make an informed choice about whether or not she's going to continue to have the opportunity to reproduce. So coercive sterilization. And so it's something that happened to a number of people. It's not just specific to people of color. However, some of the statistics that they have been able to find have been horrifying, such as in North Carolina, they were sterilizing people as young as 9. And again, this was in support of the idea that we needed to determine, that we could determine who had the right genes in order to make us the strongest society. So the law would allow for people to determine that people could be sterilized if there was a thought that their progeny would be feeble-minded or somehow weak. So again, there is a wonderful, we have some resources at the end that we'll talk about that will help us to learn more about some of the harms that practices like this have afforded our society. And again, I think I mentioned this before, and I'm going to be repetitive on purpose. The challenge that we have with racism is that it's not in the past, right? So we continue to have these instances that continue to remind us of the past. Sometimes it's an echo, sometimes it's just sort of like this subcultural sorceress. So it's a place between our subconscious and our conscious that allows for this sort of persistent sense of distrust in the institutions that seem to not value us equally. And so in I think 2010, there were some reports of ongoing coercive sterilizations, primarily in the prison population. And as recently as last year, there was a whistleblower who reported that there were women at the border in the detainment camps who were also being sterilized without their permission. And so this is an ongoing problem. It seems to happen to people who are disenfranchised or disadvantaged. Again, an example of structural or systemic racism, and also an opportunity for us to recognize and give us an opportunity to act. So again, the challenge with racism is that it's an ongoing and a very active system. Next slide, please. So I want to talk a little bit about the Tuskegee Experiment, not a lot. But I find that people can sort of go to the Tuskegee Experiment as the go-to for the reason why there is this distrust in the African-American community against the US government, against the medical field. But I think, again, it's a little bit more nuanced than that. you know, when the Tuskegee Institute, that later became Tuskegee University, established by Booker T. Washington, it really was a source of pride in the community. There was this idea that we would be able to provide educational opportunities for African Americans that were not very common during the time that the university was established, the Jim Crow era. And the idea was to build on self-reliance. Booker T. Washington had this great plan about how to help us be able to advance ourselves financially and be able to grow our communities. And so there's all this positive energy around Tuskegee Institute and what it can do for the Black community in America. Then we have the Tuskegee Airmen, who were the first Black military aviators in the U.S. Army Air Corps, and they were trained on Tuskegee base, and they went on to do extraordinary things in the Army, despite being discriminated both when they were in the Army and outside of the Army. So Tuskegee has sort of this, connotes a certain type of pride, a certain type of strength, a certain opportunity to overcome, a certain opportunity to, or example of persistence. So something positive. And what I find that's so ironic with racism is that not just that it devalues and dehumanizes and oppresses the Black people, but it co-opts components of our culture and then tries to use them for their own gain or use them against us. And so, in fact, I do think that something like that is what happened with the Tuskegee Experiment. So, as you may know, the Tuskegee Experiment is something that went on from 1932 to 1972. Next slide, please. And it was an experiment by the United States Public Health Service. And what they wanted to do was have a natural study of the progression of syphilis. And so this time frame, 1932, 1972, is when Jim Crow was still in place. We were the Great Recession was going on, and so they offered 600 Black men who were a part of this study that they would give them free meals, and that means a lot if you consider that they were Black in the South, and that this was during the Great Depression. And then they offered them free medical care, and then they were going to pay burial insurance for them. It was only supposed to happen for 6 months, and it ended up going on for 40 years. And the cure for syphilis, penicillin being used to cure syphilis, was available as early as 1947. The issue with what happened is that these people were not fully informed of what they were signing up for. And so even though the cure was available, they deliberately did not inform people of that possibility. And in fact, there's some evidence based on letters that were found that one of the doctors who was involved in the study was specifically wanted to make sure they did not get access to the cure. So there were 256 people who registered for World War II. And when they were found to have syphilis, the Public Health Service told the powers that be that those people who were part of the study should not actually be immunized so that they could continue in the study. Whereas people who were in the control group, if they happened to contract syphilis, they were felt to not be a part of or of value to the study. So they were allowed to be immunized. Essentially, the people who were in charge of this project felt like it was appropriate to continue to allow these people to suffer from syphilis without cure because two things. They thought that African Americans had a different progression of syphilis where it would have more problems with the cardiovascular system than with the nervous system. And they also thought that this was an appropriate study in order to advance humankind. And it strikes me that they must not have considered the Black people who were their test subjects as humankind, otherwise they would have been treated differently. So as a result of that study, 128 men died, either from syphilis or the complications of it. 40 of their wives contracted syphilis, and there were 19 known children that were born with syphilis. Now, there were some reparations in that the medical insurance was guaranteed for life for the survivors of that experiment. However, and we even got a presidential apology that presidential apology from President Clinton from the nation happened in 1997. But I want to talk to you about another experiment. Next slide, please. So again, remember how I'm talking about sort of the repeated traumas, almost like, continuing to poke a wound. So the New York State Psychiatric Institute conducted some experiments. Now, the report was in 1998, but the actual study was over the course of 1993 to 1996. And what they did was they had 100 males, most of whom were Black or Hispanic. And I say males, they're children. So there were 6 to 10-year-old Black or Hispanic boys. They had brothers who were determined to be delinquent. And so they did some research through court records, found mothers who had aversive rearing practices, whatever that is, and gained permission for the price of $125 to inject their 6 to 10-year-old sons with a medication called fenfluramine. Now, fenfluramine is part of fen-phen, which is a diet drug that was removed from the market because it caused some adults to develop heart valve problems. And what they were trying to measure is the association between a certain level of brain chemical and violent behavior in Black children or children of color. So that was 34. And then the other 2 experiments that incorporated the 66 boys, these boys were aged from 7 to 11. They had ADHD. Their prescribed medication was discontinued, and they were given the IV fenfluramine as well. And again, trying to measure a relationship between a certain level of chemical and the violence. So just the premise that we would need to focus on children of color to determine the relationship between a hormone and violence, as if children who are not of color don't have, similar dispositions, is just really tragic. And again, it speaks to how our entire system is challenged and limited by racism. And so remember I said that the presidential apology was given in 1997 for an experiment that took place between 1932 and 1972. This happened in 1993. From 1993 to 1996. The article's in 1998 because someone leaked the information. But the fact of the matter is, what is the value of an apology? If we're going to continue to do the same thing and to dehumanize and devalue Black lives. So there are continued insults that support the notion that Black bodies are not valued by science. So this is part 1. And we'll talk about how Black bodies are not valued by our government and our legal system in part 2. Next slide, please. Okay, so want to continue on the theme of how racism interferes with our ability to achieve mental health equity. Perceived discrimination has been shown to contribute to mental health disorders among racial or ethnic groups such as Asian Americans and African Americans. Is that true? Fact or fiction? 5 seconds. If you said fact, you were correct. So as I mentioned before, there has been wonderful. As I said before, there has been a growing body of research that shows that racism actually causes significant physical health and mental health problems, but perceived discrimination is a little bit different. So it's not like the systems that are in place that reduce opportunity. Perceived discrimination is actually just the anticipation of someone acting on their prejudices and biases. Next slide, please. So I'm going to be going just a little bit faster because I want to make sure that we can get through the rest of this presentation and entertain some of the questions and or comments that you all are sharing. And I appreciate how interactive you're being. So perceived discrimination is a perception of a behavioral manifestation of a negative attitude, judgment, or basically unfair treatment of members of a group. And next slide, please. So again, here comes this theme, this common theme of repeated exposure. So the idea is that the recurrent exposure of to discrimination can actually cause someone to actually anticipate that discrimination. And again, it's the perception that something's going to happen that actually activates the stress response. And the stress response will actually lead to suppression of the immune system and can do things like shorten our telomeres and lead to us aging faster and lead to us having a higher morbidity with certain diseases that I'll talk a little bit more about in, I believe, a coming slide. So next slide, please. Essentially, this is just restating what I mentioned before, which is that in African Americans were polled, and most African Americans report that they will have had some experience of racism or racial discrimination over the course of a year. And so, and of that percentage, even more, we'll talk about it having occurred multiple times throughout the year. So there's this idea that there's this ongoing insult to people, and that leads to them sort of having an anticipation of discrimination, which activates the stress cycle. Next slide, please. So this is an advertisement that was run in Australia, and I love it. It really identifies that racism is a public health problem. It is not a Black person problem. It's not a white person problem. It's a systemic issue that is a public health problem that is preventing our society from realizing its potential and is contributing to our society being as fractured and divisive as it is today. And so really briefly, when we experience stress, we have a biological opportunity to prepare for danger. It's the fight or flight response. And so when that happens, there's a series of hormones, like cortisol becomes active, catecholamines become active. There are that allow us to redistribute the blood flow and helps us to have more blood flow to our cardiovascular system, our musculoskeletal system, and our nervous system in order to prepare for whatever the danger is, right? And so the way that we're programmed, the thought is that it would be a temporary state of being, right? So we can afford to sort of redistribute these hormones and our blood flow in order to address a particular danger at a particular time. Right. So it's supposed to be an acute response. But if we are in a situation where we continue to have this ongoing stress and it's day after day in the work environment, in the public environment, maybe even at home, then instead of it being an acute response, it becomes a prolonged or a chronic response. And our bodies just weren't built that way. We have this system where we try to balance things in our body, but that becomes a maladaptive form of processing within our system that, again, leads to us aging early, having higher complications from certain diseases, maybe even having a higher likelihood or higher prevalence of certain diseases. So again, there's a biology to racism that we are now able to better understand, and hopefully that will help us to be more motivated in the urgency that I have that we should actually be trying to address this on a systemic level. Next slide, please. So we've offered too much information now, and the fact that of the many ways in which we have an active distrust of the healthcare system. So it's not just something that's historical, it's current, and it's because there are ongoing issues with how Black people are actually treated in the healthcare system. Again, so many more examples, but I want to make sure that we leave time to address your questions, and we'll also have the opportunity in part 2 to discuss some of these things. We talked about stigma. Again, I really want you to consider the overlap of internalized stigma, internalized racism, internalized structural and stigma and structural racism. We understand about the things like lack of insurance or underinsurance preventing us from being able to actually access care. And then 2 things. There's multiple studies that show that when Black people are cared for by Black providers, they have better health outcomes. Literally, there's a higher likelihood of Black children who are born living, of Black mothers who give birth surviving. There's studies that show that if a Black provider cares for a Black person who has an issue or requires pain management, they'll have better management. There are studies that show that that people are more willing or feel more comfortable, I'll say, in sharing certain information that allow Black providers to be able to provide better care. Lack of culturally competent providers is something that we really need to address, because we don't have enough people of color who are in the practice of medicine. Next slide, please. So, fact or fiction, only 1 in 2 Black adults who need mental health care receive it. Five seconds. If you said fiction, then you were right. It's actually 1 in 3, right? So 1 in 3 Black adults who need mental health care receive it. Please. Let's try to put some of these things together. Okay, fact or fiction. As of 2018, 11.5% of African Americans are uninsured. 5 seconds. If you said fact, that's correct. So again, a lack of insurance and ability to pay. Even with the introduction of the Affordable Care Act, there are still quite a few African Americans who don't have adequate insurance. Next slide, please. Okay, so 20% of African Americans are more likely to report serious psychological distress, including things like sadness, hopelessness, worthlessness. Next slide, please. And that's compared to their white counterparts. Again, 1 in 3 Blacks who need mental health will receive it. We talked about the higher likelihood of adult males during a certain period of time to be diagnosed with schizophrenia. And it really was a way that they were mischaracterizing the fervor around fighting for civil rights. And then there's studies that show that African Americans who have similar symptoms as their white counterparts will not be provided similar care. So they won't necessarily be prescribed antidepressants or given the appropriate therapy. Next slide, please. So go for it on your own, but this is the strong Black woman syndrome, or the Black superwoman syndrome. And the reason why I wanted to talk about this is because it's, again, to me, it offers this example of the incredibly harmful impact of internalizing stigma, internalizing racism. So this is a term that was coined by Dr. Cheryl Woods Giscombe, and it has 5 basic tenets. It's that there's an obligation for a Black woman to be strong. There is an obligation for a Black woman to succeed. There's an obligation for a Black woman to help others. There is an obligation for a Black woman to suppress her emotions. And there's an obligation for a Black woman to not be dependent or vulnerable. And it's those tenets are tied up in this drive to succeed, to thrive despite having limited resources. And that is tragic because it's at the expense of self-care. And so Dr. Allen actually described that this process leads to the slow deterioration of our bodies. And so there is a male counterpart to this. If you go to the next slide, please. And that is John Henryson. So this term was established by Dr. Sherman James, who is epidemiologist and psychologist. And again, it's the male counterpart where it has 3 components. There is an efficacious mental and physical vigor. There is a strong commitment to hard work and a single-minded determination to succeed. And again, it sort of tries to capture that idea that there will be a heroic or superhuman effort of an African-American male to try to succeed or thrive despite so many things that are limitations based on the fact that there's so much structural structural racism and racism and discrimination. So if you wouldn't mind playing this video.
Is the skin you're in that matters. You are consciously aware of being a Black person in America. Your system responds to that. I was not surprised that the pandemic had the disparate effects that it did on African Americans. I am the originator of John Henryson theory, which posits that repeated higher for coping over years, over decades, with very difficult life circumstances can really cause damage to the cardiovascular system and then eventually lead to high blood pressure, heart attacks, and strokes. The John Henryson theory takes its name from the legend of John Henry, the steel driving man.
Some said he was born in Texas, some said he was born in Maine, but I don't give a damn where that poor boy was born. He was a steel driving man. Lord, now he was a steel driving man.
John Henry engaged in an epic battle against a newly invented steam drill, and he beat the machine, but he dropped dead after his victory from complete mental and physical exhaustion. You have today, in 21st century America, so many African Americans who are caught up in a John Henryson situation, who are faced with real adversity, deepening economic hardship, loss of jobs, loss of health insurance, threats to one's sense of personhood, one's sense of dignity. The stress is enormous, and people don't give up. That persistence, working twice as hard, over time can really impair multiple physiological systems. By the time they're in their 20s and 30s and 40s, they're already having things like high blood pressure, diabetes, obesity. Now along comes the pandemic, and they are susceptible because of these underlying conditions, and yet they have to try to make a living. That's the John Henryson situation. It's on display.
Okay, next slide, please. Thank you. So there's 13.4% of Black people in the United States, and about 7 million people are in need of mental health care. Next slide, please. So, okay. So fact or fiction? In the interest of time, this is a fact. We only have 4% of psychologists, 2% of psychiatrists are Black, and 5% of physicians. And there's just no way that Black people alone are going to be able to meet the need of Black people. And that's why we need to do a better job of figuring out how to help people be culturally competent. Next slide, please. I'm sorry, would you go to the slide before, please? Right there. So, nope, I'm sorry, next slide. This is the remedy. So essentially, I'm going to streamline the last few slides. The underlying thing that we need to do is figure out how to communicate better. Right? Communication will really help us to mitigate racism. We have to figure out how to talk about racism. Remember that approach. You know, we have to talk about it, think about it, take action, and then things will change. That's what we need to do. Next slide, please. So we can talk in more detail, maybe during the discussion about ways that education are going to be important, and that's being able to empower ourselves to address racism. Advocacy, we have to act on what we know and what we believe, and then, you know, research, there's just such scientific bias, as was shown by some of the things that we discussed earlier on. Please, next slide. So this is an invitation to all of us to consider becoming anti-racist. And the thing that's really different about I agree, but the term anti-racism is that it's not just a belief, it's not just a system, that everybody's equal and deserves equal opportunity. It's also an invitation or a challenge, if you will, to actually act on what you believe. What are you willing to sacrifice? What are you willing to do to kind of make a change in our society so that we can live in a better society and that our children can inherit a better society? Next slide, please. Again, want to talk about it, think about it, take action, transform. Next slide, please. Just a reminder that we have an idea. We know that there is a direct link between racism, racial discrimination, and poor health outcomes, increased depression and anxiety, mental health challenges. Next slide, please. So hopefully everybody's still awake or woke, if you will. And so we not only want you to have the opportunity to feel like you've learned something from this presentation, we hope that you'll join us in our next presentation, and we would like to be able to take some questions at this time. Very much appreciate your participation, your attention. Again, I want to specifically thank Jamal, Mark, Nancy, and Dr. Peterson, and all of you for being willing to learn and allowing us to share some of our passion about what we think is this very important topic. Thank you.
Amazing, amazing. I'm going to jump right in because thank you so much, Dr. Peterson. What an extraordinary presentation, and the response has just been frenetic. Lots of folks you can see there on the chat are chiming in and responding. Thank you, just absolutely excellent. I want to try to just jump in, and we're still taking questions in the Q&A. So if you can post your questions in the Q&A, we'll try to get to as many of them as possible. Dr. Peterson, an anonymous attendee said this video was disheartening. I think they were talking about the first video because it is the truth. It's real life. It's frustrating to know that many may be learning this for the first time. But the question that this anonymous attendee asked is, how do you yourself handle having to teach and explain material that is emotional and historical? I mean, obviously we could have had some trigger warnings around some of the stuff that was presented here, but how do you yourself manage having to teach and educate around these traumatic concepts?
It's hard. I'm blessed with a wonderful support system in my family. But I won't deny that it's difficult. And when we see what we see on the news, it becomes even more difficult. I just had a long conversation with my mom about how I was working on this presentation, and it already sort of had me at a certain level of awareness and, quite frankly, agitation. And we were processing the what was reported on the news about the 9-year-old child who was pepper sprayed, and how she had to tell the police that she was a child, and just sort of processing that. So again, because there's constant insults to the issues that we're dealing with, and I will tell you that it's hard, but it's necessary. And I think one of the ways that I'm able to continue to do this work and hold on to the passion and the purpose is because I'm still learning. I'm still learning about what racism is and what my racial identity is as I define it versus someone else defining it for me. And so I would just encourage, I think one of the things that is helpful is when we're able to grow, and when we're able to grow, we expand. There's greater space created to be able to accommodate the knowledge that we receive. So it's difficult, but it's worth it. And I'm a woman of faith, and I believe that God helps me in this.
Mm-hmm. Mm-hmm. Thank you for that. Another anonymous attendee says, I deeply appreciate this webinar. As a white person, I struggle often with intense guilt over how white people have treated and unfortunately continue to treat people of color. This training has brought me to tears. How do I cope with these feelings of guilt and shame?
That's one of the challenges that we have, right? Like, it is really hard to talk about racism, but if we can get ourselves to a place where our discussions on racism are not about blame, where they're really just about understanding what was, what is, and then committing to what we need to do to make things better, then that might help us to have greater agency in being advocates, as opposed to worrying about, blaming ourselves. Our history is what it is. And the more we can learn of what our history really was, as opposed to what we were taught, 30 years ago, 40, 50 years ago, I think the better served will be to try to truly affect change. So I think, again, the approach is to talk about it. Think about it. Why are you feeling guilty? Where is it that the shame is coming from? And then what are you going to do about it? The invitation is to be a proponent of anti-racism.
Nicole Dunn asks, how can we educate young Black women who are conditioned to believe that they have to sustain this superwoman archetype at the cost of mental and emotional decomposition, reinforced by older generations who are conditioned to sustain this mindset?
Dare them to be different and give them the health stats. We're dying at younger ages and have worse complications of things like heart disease and diabetes, all stress-related, impacted conditions. So we have a choice, right? Let's empower them with education. Let's equip them with the history and the opportunity that is rightly theirs, regardless of what systemic racism tries to tell them, and see if they don't have the opportunity to make a better choice.
Thank you for that. Someone has asked if they can get a list of references, and I know that's in the presentation itself. So hopefully we were able to at least scroll through and capture that for the recording. Dr. Peterson, another anonymous attendee, and I want to share this, but I don't know if it's worth your time to necessarily answer this question, but another anonymous attendee says, in a few sentences or words, explain why racism is a public issue and not a personal trouble.
Because it diminishes the capacity of our society.
Excellent.
May I ask a question from YouTube?
Yep, sure.
All right. Dr. Peterson, how do we have a courageous conversation with coworkers and hope they understand and that it's not complaining?
So in a work setting, it's going to be really challenging, right? I do believe there are certain things that should not be discussed at work, but racism is not one of them. But I do understand how difficult it is. And so I would make sure that there's preparation with the powers that be, meaning the administration, and that there's an opportunity not to have one conversation, but to have a series of conversations where everybody's able to bring their concerns, their knowledge or lack thereof to the table with someone who is equipped to be able to try to address concerns. So it's not about complaining. I think talking about racism, not race, but racism is an opportunity for any business to become better, because racism is a problem in our society. It's a problem in our corporations. It's a problem in our communities. It's a problem in our homes. So I would try to have a series of conversations, try to make sure that you have management buy-in and support, and that you all prepare yourselves for the fact that that racism, the idea of racism, talking about racism will, especially if someone's really open to trying to understand and to change, is really going to involve some negative emotions before we can get to the place where we're able to focus on advocacy and change.
Thank you.
Mark, do you have any, and you want to take a couple more from YouTube? Because we got a bunch. We will not get through all these questions, folks. We're going to try our best to do so, but I don't want to privilege the Zoom webinar folks over the YouTube folks if there are a couple others you want to feed in.
This may be really good for all of the audience. How is there any special ideas that you have about talking about this with children?
So I don't think, one of the things that I didn't talk about is we don't have, there's not enough research, but there's not enough literature, and there aren't enough toolkits for talking for adults or for children. But I think that children are remarkable. I'm a child psychiatrist, by the way, right? So I think that one of the things that it would be important to do when you're talking to a child is just trying to understand how they conceive themselves, right? And then helping them to ascribe value equally to everything, and to empower them to be self-determining versus having their sense of self and value externally determined. I cannot count the number of times that my siblings or I might have said, well, Susie Q gets to do such and such, and my parents would be like, but Susie Q is not your parent, so you're going to do what your parent tells you to do. So I said it to say that the parent or the person who's working with the child can really establish an environment and where they're able to be the defining and determining factor in terms of how a child actually understands race and understands their racial identity, their ability to define themselves, and what role they want race to play in it. I hope that answers the question.
I hope it does too. We had a great group on YouTube, and they answered all of your survey questions. So as more questions come in, I'll let you know.
Yep, thank you for that, Mark. Dr. Peterson, Sarah Rifkin says, you mentioned that 1 in 3 Black adults who need mental health treatment get it. Do you know if the number is the same for Black children and adolescents?
I don't. But the statistics that are available for African-American children and mental health are deplorable. Quite a few children with mental health problems end up in the juvenile justice system, and that's actually where they have their first contact with mental health, and the misdiagnosis and the inappropriate treatment is truly saddening. But don't have that statistic available right now.
Carol asks, how much damage has been done to forward progress on racial equality from the last 4 years and the attitudes of the former president and his allies in government? I don't know how political you want to get here, Dr. Peterson.
So my initial response, as soon as you said for the last 4 years, I was going to say incalculable, but I actually want to be a little bit optimistic, because I am. When we, if you look at what Black Lives Matter marches looked like 6 years ago versus what they look like in this past year, I'm encouraged. More people are understanding that Black Lives Matter is not a movement, a Black person movement. I don't know how to say, it's not Black Lives Matter is an anthem for our entire society, not just Black people. And I think because of the unfortunate publicized demise of George Floyd, in the context of so many other people who have lost their lives in similar ways in contact with the police, that there's a greater awareness of how, if we cannot do a better job of addressing racism, that we will not survive as a society, much less thrive. So optimistic.
Awesome. Saudi is asking in the chat, I work at a psych hospital. I notice Black children are more likely to get a chemical restraint than white children. How can I address this in the workplace?
Silence is compliance. Speak on it. Share your concerns with the people that you who are in a position to actually address it, and continue to speak on it until there is change.
Taylor asks, in your experience in psychiatry, how have you balanced understanding and empathizing with patients of color around their reluctance for pharmacological intervention, while at the same time recognizing that this may sometimes be in their best interests?
I respect choice, and I consider myself a health partner, and I do my best to provide education to empower those with whom I have the opportunity to share care, and I'll continue to do everything that I can to help them be able to make the best choice, and to respect them if they don't make the choice that I think would be in their better health interest, and then work together to get to a better quality of life for the patient, regardless.
Excellent, thank you. Michelle asks, my question or comment is about peer support specialists moving into an area to sit on boards and to try to change policy. I'm a peer in a PhD program and want to move into the spaces where policies can be changed to impact the structural racism in behavioral health agencies. Do you have any thoughts or advice on that?
Absolutely need to sit at the table.
Ruth says, how do you deal with people of color reinforcing those ideas that Black or brown people are lazy and that the Black Lives Matter movement protests were an excuse for looting?
I think that the first step to achieving change is communication. We need to try to understand why someone would think that, and then see if they're willing to actually engage in an exchange of information. Not everyone is willing to communicate, and meaning an actual exchange of information and then even when information is exchanged, not everyone is willing to allow themselves to change in response to the information they receive. But the first step will be communicating.
Alexander asks, how can those who are employed in educational environments, especially higher ed, help to make the institution more warm and welcoming for people of color who may be coming in with a history of racist, traumatic experiences in public education?
Mentorship is key. So I think, but the mentorship needs to be strategic, right? So I think there should be mentorship. And I also think that, again, the people who are already in the institution of higher education, if they feel so led, should be advocates for trying to almost act as consultants for people who may not be as aware or may not be as woke, so that they have the opportunity to actually become more culturally sensitive. And I believe that if they're more culturally sensitive, they become more competent. And if an educator's role or goal really is to educate to the best of their ability, then hopefully they would be open to that.
Cynthia asks, how do you reach an organization or organizations that are institutionally racist in their practices, but they conduct business as though racism does not exist?
I am blanking on the author, and Dr. Peterson, maybe you'll remember, I think this came out when I was in college, and it was a book that basically said that racism no longer, Shelby Steele?
Shelby has a book called The Content of Our Character. There are lots of...
No, not that. I'm sorry. Anyway, so there's a book that I read that was written by a Black scholar that said that racism no longer exists. So it can come from anywhere. So I think that again, the it's important to be able to find advocates to sort of try to find an ally, if you will. And if you can find an ally in that system, then that will help you to get to a place where you can talk about it, get them to think about it, and then take action, and then actually transform. However, when there's not an ally, talk about the bottom line. Sometimes people are motivated by the bottom line. And if you can actually propose that increasing awareness will lead to increasing profits, that actually can sometimes affect change.
An anonymous attendee asks, first he or she says, thank you so much for this. I'm wondering, and Dr. Peterson, just so you know, there's a lot of chatter during the presentation about COVID, because all the information you're presenting around the history of medical malpractice directed at Black folks is making folks think a little bit about why there's so much hesitation and so much resistance to the COVID vaccine, right? And so this person says, thank you so much for this. I'm wondering about how to talk to my clients about the vaccine when they have questions. And this person is a therapist, and 90% of their clients are Black, and they have questions about the vaccine while also holding space for the historical fear stemming from the things that you talked about here in your presentation.
So I'm going to maybe be more honest than I should be right now. And I'm going to tell you that I told my family that when they first talked about the immunization being available, that I didn't want us to get it yet. I wanted us to have more information, and I wanted there to be more people that actually got the shot, because I too had that subcultural susurrus that tells me that we need to be wary. Still, I will not allow, to the best of my ability, any of my family members to be in the hospital overnight by themselves, because of what I understand to be the biases that are inherent in medical practice. And I am a medical practitioner. So again, that's from a point of honesty. But I'm also a medical professional, and I understand what we need to do in order to be able to contain the virus. There are millions of people who across the world who have been able to take the virus. And I do believe it's going to convey protection. And I think it's necessary in order for us to be able to address this pandemic. We need to get through this. And Black and brown bodies are suffering more from this disease disproportionately than others. And also, we're dying from it more. And I have a father who's 91 and a mother whose age I will not state. And I want my parents to live. I want them to be able to hug their grandchildren again. I want to be able to see my sister without a mask and through a door. And the vaccine is the avenue to that. And so I will tell them, one of my sister's friends actually said she thought that the Tuskegee Experiment was the government giving syphilis to the African-American males. And she had heard that there was a sterilization component in the vaccine for COVID. So that's how sort of history gets changed and ends up in people's, what fear does. And so what I would say to your patients is, first, I'd like to have them actually articulate what their fear is, find out specifically what it is that they're afraid of, and then give them the science, give them the evidence that so many people take in the vaccine, that we have more increasing studies that are showing that people who take the vaccine are less likely to die from it, and that science suggests that this will be helpful, and then give them examples of all the other vaccines that we've taken, right? Or at least that people in my family have taken, like the measles and mumps and rubella, polio, things that actually protect us. Vaccines are helpful, and there's been a lot of debunking of the theories of the vaccines causing disorders. So I do believe that the vaccines are in our best interest, and that they'll just continue to improve on what the vaccines are able to do to help us as things go along. So I would encourage them to do research, because it's so very important. And if enough people don't get vaccinated, we'll not be able to manage this pandemic. So please consider sharing that information.
I love that answer, Dr. Peterson, because you're right. You have to be able to hold space for the misgivings and the fear that Black people have, just based on what you presented in this presentation right here today. You have to acknowledge that. You can't ignore it. But then you also have to come with the facts about what's happening and how this is disparately impacting our community, and why we need to take the vaccine.
And I'm sorry, Dr. Peterson, I just want to be clear. I just want to close that out with saying I have asked everyone in my family to get the vaccine. We are registered for the vaccine. So I am encouraging people to consider to do their research and consider getting the vaccine. Sorry, go ahead.
I have one question from YouTube.
Yes.
Okay, we're coming up on close. What are some of the ways we can adjust our treatment approaches to account for the effects of racism in mental health?
Studying, right?
Studying.
We need to be active learners of racism. We need to be active learners of real history, not just what's, we have to, so the things that you will be taught in school that is not a comprehensive history of the United States. And so I think being able to challenge ourselves to be active learners and then sharing what we learn is and then being willing to talk about what we know and accept what we don't know. Those are things that I think are an important component of being able to be better practitioners and being available to our patients in ways that will establish a higher level of rapport.
Yeah. And the other piece I heard you say time and time again was having the conversation.
Yes, communication is just so important. Yes, sir. We got to talk about it, think about it, take action, and then we'll transform.
So Dr. Peterson, we have a couple minutes left. There's so many questions still left on the table. So some of the things that keep coming up is some of our friends out there who are, I'm assuming are white, are saying, how do we talk about this without offending? How do we have this conversation without offending people? I want to talk about race, but I don't want to offend anyone. And then some folks are asking, like, what are some of the things that we can do to start on this anti-racism journey? Like what, people can read and do research, but are there other things that people can do? So one is like, how do we bring up the conversation because it's so sensitive? The other is like, are there some actions that you might suggest we start taking? It is Black History Month. What are some things that folks can do?
So first of all, I'm so grateful that people are even willing to think about talking and think about how to change and be more open. And so what I think is that we need to come from a place of authenticity, and we define people who are actually authentic. Because if you're not talking to someone who's authentic, then you're subjecting yourself to, a miserable conversation. So I think, again, it starts with us. So we need to make sure that we are actively trying to learn. Anti-racism is a relatively new term. And I think trying to understand it, there are lots of resources out there on it, might be able to give us some clues. There are so many resources on how to talk about racism. And so look it up, Google anti-racism, look up racism toolkits. And again, we do have we do have at the end of the presentation some recommendations for the resources that we use for this presentation.
Lots of folks asking for the presentation itself, and I just want to be clear, Nancy and Mark, there is going to be a link that will go out to the recording of this presentation, correct?
Yep, that's correct. So we'll have, yes, it'll go out and it'll be on an email, and you can get it on our website, which is pacarepartnership.org. And if you go up there into the trainings, you'll see the webinar, and we'll hopefully get the video posted up in about hopefully 2 to 3 business days, and have the PowerPoint there as well if everything works out.
One last question, Dr. Peterson. This is from Jacqueline. As professionals, are there organizations that we can support that actively work on encouraging more people of color to enter the mental health professions?
Yes. So the American Psychiatric Association, the American Association of Child and Adolescent Psychiatrists. So there's several that actively, and I'm saying it from that's just off the top of my head, but I'm sure that there are other organizations in terms at the level of psychology, like the APA and the social worker or national social worker organizations that really are aware of the benefit of having a pipeline for African Americans into our professions. So yes, there are several organizations that have acknowledged the need and have actually tried to establish pipelines or opportunities for us to increase the number of people who are practicing.
I want to again thank the entire PA Cares team for inviting us and working through all the logistics of it and providing the on-site support for this presentation. I want to thank my lovely and extraordinarily talented sister, Dr. Eunice Peterson, for sharing her insights and her experiences and her research about the impact of racism on mental health care and on mental health care communities. I want to thank everyone in the audience, all the questions. I'm sorry we could not get to all of these questions, We did the best that we could. You guys know there's a part 2 coming up February 25th. Please register for that one. We'll talk a little bit more about microtraumas and microaggressions and talk about some of the contemporary ways in which the history that Dr. Peterson shared with you today shapes mental health practices and mental health communities. And so we're looking forward to that piece. But right now I'm going to turn it back over to Mark and just say, again, great job, Dr. Peterson, and thank you everybody else for participating.
Absolutely, yes. Thank you, Dr. Peterson's presentation, and for speaking about the importance of mental health in our communities. A part that was, I think, just really meaningful to me was really how you were just so emphatic about just having these bold and caring conversations and really talking and having those conversations and putting it out there. As Dr. Peterson said, February 25th at 2:30, Black Mental Health Matters Part 2. We're expecting just as large a turnout, and we'll have the same setup. So if you don't get in, you'll be joining us on YouTube, and you'll be absolutely part of the community.
Thank you.
Dr. Peterson, I wanted to personally thank you so much for your honesty and your openness and your courage, and for taking time out of what I know is an extremely busy life to do all the work to present to us today and to come back again in 2 weeks. I am very proud to have been a part of this. Thank you.
Thank you. My pleasure.
Safe, everybody. Thank you.
Thank you.
Thank you.
All right. Thank you all.